Hello, welcome, and thanks for joining us to help choose home when care is needed, a podcast all about the benefits, value, and safety of receiving care and services in the one place that feels most comfortable, wherever it is that the person needing care calls home. I'm your host, Marilee Orsini, and I've been involved in healthcare at home since 1981. Before we meet today's guest, a brief thank you to our sponsors and partners, the National Association for Home Care and Hospice, Access, and Core Cubed. Today's episode is number 19 of Season 3. Our guest today is Fran Hoh, an advanced practice nurse, board certified in hospice and palliative care, and founder and CEO of Palliative Rx. Please help me, won't you, and welcome Dr. Fran Hoh to Help Choose Home. Welcome, Fran, to Help Choose Home, and thank you so much for joining us today. I'd like to start with you first telling me a little bit about Palliative Rx and what types of services that you provide through that company.
Great. Thank you for having me, by the way. I'm really happy to be here. Palliative Rx is a program that does online education for patients and families that are suffering with chronic serious illness. Illnesses like, congestive heart failure, COPD, dementia, cancer. And we educate the families how to, manage the symptoms, how to know what's going to come next, be prepared, questions to ask their doctor, just to help them navigate the journey. Because I think, now that COVID came, and people aren't seeing their doctors face to face as much, I think people are needing a little bit more and being able to offer online programs that are live, with me. I've been a nurse for 40 years, so having a clinician on the other end who's helped patients, create wellness for years and years is a good thing. So that's what we do.
Well, talk to me a little bit about palliative care, because that is a topic that seems to be cropping up everywhere.
I think there's so many misconceptions out there as to what hospice is and what palliative care is. So I'd really love to just, maybe separate that a little bit for your listeners.
Good.
I know that there's many areas that they overlap. Both palliative and care and hospice take care of patients that have serious illness. Both of them focus on aggressive symptom management and keeping patients' symptoms under control. Both of them treat both the patient and the family. It's not just the patient, because serious illness affects the family as well. So it's not just the patient we're taking care of. We're taking care of the families as well. And how are they managing? And it's very difficult for families to watch their loved ones when they're suffering with, chronic illness. And we also both work on goals of care. So that's what we both do that's the same. Hospice was created as a Medicare benefit for patients that had 6 months or less to live if their disease followed its normal trajectory. The problem is that 20 years, 15 years ago, doctors really weren't comfortable stating that people had 6 months to live, because they didn't want, if they said that, they thought maybe the patients might give up or maybe they might be wrong. So they didn't want to commit to a 6 months. So they waited till they were sure the patients were going to pass away, which would generally be 1 to 2 weeks before they died, and then they'd call hospice. So when you mention hospice to a family, they often think, oh, that means they only have a couple of weeks left. When in reality, hospice was created as a 6-month benefit to give patients all of these things that they need. So hospice is a Medicare benefit that you can get for 6 months and sometimes can even be extended. And it gives you a nurse that can come to the house and manage your symptoms. It gives you an aide that comes and helps you get dressed and bathe. Gives you a social worker and a chaplain that comes and helps you deal with how you're feeling about, living in the last season of your life. So it's really beneficial to have it for the whole 6 months and not just 2 weeks. So when I say to patients, maybe we should think about hospice, I'm really letting them think about a 6-month time frame so that they can get the most out of their benefits. When you choose hospice, it's generally once you've decided that there's no other more curative things that you're doing. You're not doing radiation, you're not doing chemotherapy, you're not doing aggressive things, which is the difference between that and palliative. So palliative, on the other hand, is for patients that have serious illness, no matter where they are in their illness. And it focuses on aggressively managing the symptoms, getting to know the patient and understanding what's worrisome for them, what's going to make them hit the panic button, what are they most afraid of, what's bothering them the most. Is it pain? Is it shortness of breath? Is it how they deal with their family? Is it spiritual issues? So they can still be receiving chemotherapy and radiation and all other kinds of treatments when they're on palliative. So that's the big difference between palliative and hospice. Hospice generally means they've decided that their treatments are no longer helpful to them and they've stopped them and they want to focus on comfort care in whatever time they have left, which is generally 6 months or less. Palliative care focuses on people with serious illness throughout the entire trajectory, helping them manage their symptoms, plan for what's going to come next, and just understand how to deal with this illness that they've been given.
And what's going to come next could be getting better and coming back to a lifestyle that you previously had or close to what you previously had.
Absolutely. Absolutely.
Well, what's the reticence then to use palliative care if it is in tandem with your other plan of care and your other treatment?
Well, say a cancer patient, for example, the oncologist spends a lot of his focus on your chemo treatments, your radiation treatments, your blood work, your next CAT scan, your next MRI, and doesn't often spend a lot of time on how are you feeling emotionally, how are your pain meds working, are you having constipation or shortness of breath, what are you worried about? Some do, but some don't. It surprises me how many patients we have that come in and really don't have a good understanding of what's going on with their body. They come in and they'll say, oh, yes, I have stage 4 cancer, but they don't really have a good handle on what that means, and what exactly in their body is happening to them, so that when they get a symptom, if they understand physiologically what's happening, then they understand why they're having the symptoms that they're having and better how to manage them.
But you're an advanced nurse practitioner, right? And you've been working with palliative care for a long time period.
Yeah, I'm an advanced practice nurse, and I've been an advanced practice nurse since 1987. I've been certified in hospice and palliative care as an advanced practice nurse since 1992. So I've been doing this a long time. I worked in geriatrics. It's so interesting. So many people that end up being palliative care started out in critical care. I started out in critical care. And, that's where I learned that there's a lot of things that we can do that maybe we necessarily shouldn't do. Maybe just because we can doesn't mean we should. And then I worked in geriatrics. I worked in nursing homes for 10 years. And I realized that we really need to do a better job at taking care of our patients in the last season of their life. We really don't prepare them. We're a country that doesn't like to talk about death. We have a broken healthcare system, and it's very broken around end-of-life care. We do a lot of treatments that are sometimes futile. We don't project life expectancy as well as we could or should. We don't treat symptoms as well as we could, as aggressively as we could. So I think there's a lot of room for improvement in palliative care, and it's been growing and growing over the last 10 years, into there are board certified physicians, board certified advanced practice nurses, board certified nurses in hospice and palliative care.
So as a healthcare delivery system, how is it that we start integrating this end-of-life care, or at least understanding of when is end of life? I think that's probably one of the biggest questions I have, because choosing to go with hospice or choosing palliative care means that you are making an active decision, correct, about your the trajectory of your healthcare treatment.
So hospice and palliative are different. So when you choose a hospice trajectory, you're understanding that your life expectancy is probably going to be less than a year. When you're choosing a palliative trajectory, you're focusing more on your quality of life, managing your symptoms, and preparing for what comes next. And as you said before, you may get better or you may get worse. There may come a time when you need to transition into hospice, and palliative will help you do that. We definitely need to incorporate it for sure, into our long-term care facilities. Prior to me starting this company, I had another company called Always Think Comfort. And what I did for 10 years is I went into nursing homes. Me and 6 other nurse practitioners were in 35 nursing homes in New Jersey doing palliative consults and pain consults. And there was no competition for me. There was no one else doing that in New Jersey. And it's amazing that the place where people end up dying, which is nursing homes, should be the place that has palliative care, because people are dying there. That's where they go at the end when they're going to die. However many years they have left, they may have 3-4 years, but that's the last place they're going to be. So we really should be doing palliative care in the long-term care facilities. And it's not. It's in most hospitals, which is great. And now there are some outpatient programs starting, which is great. But we still need to do more in our nursing home population. How much
of the cause of not explaining palliative care lies in the reimbursement? Because my understanding of it is there's not any formal reimbursement for palliative care, or am I incorrect in that?
Well, palliative care is billed under just as a regular visit, right? So palliative care is not a money-making service. It's a money-saving service. So for every patient in the hospital that sees palliative care, we save the hospital $1,200 approximately. So that is by referring the patients to hospice and getting them home on hospice because it's appropriate, and then they're not going to come back to the hospital in that 30-day window. By talking to families about tests and procedures that may not make a difference to do at this point in the disease trajectory. The benefit may not outweigh the risk of doing that procedure. So we save money on procedures. Getting patients, out of the hospital sooner saves the hospital money. So there are many ways that we save money for the hospital system, because we don't do things, we do a lot of things in this country today. Our numbers of what we spend in medical care is significant. In Jersey, they looked at end of life, and like in the last 6 months of life, most people see 12 consultants. I mean, that's a lot of people to be seeing somebody in the last 6 months of your life, So how can we save money? Palliative is a saving service more than a generating service. But as far as billing, we bill the insurance companies under, a visit, just like any other. If we see you new, it's a consult. If we see you for a follow-up, it's a follow-up based on the level of complexity, based on how it's covered. So the visits are covered by insurance.
The visits are covered. You're talking about a professional, someone seeing a professional to talk about.
Oh, yeah. So if it's a physician or an advanced practice nurse, right.
Right. For a consumer who is faced with a loved one who has a serious illness and may not be ready to say that they're 6 months, that they're in that 6 month window, or the family may not be ready. Somebody's not ready.
Right.
So what questions do you ask about your plan of care or your treatment or your options? What could a consumer ask a healthcare professional to make certain that someone was paying attention to their wishes and not just throwing procedures at them because there are procedures?
That's exactly the question. And we work with families all the time and telling them this, One question is, I used to work for a geriatrician, and he used to tell me, if you go to a barber, you'll get a haircut. If you go to a surgeon, you might get surgery. If you go to an oncologist, you might get chemo. If you go to a radiation oncologist, you might get radiation. So the question to always ask is, if I do this procedure, if I do this radiation, if I do this chemo, if I do this surgery, what is the next year of my life going to look like? If I don't do this surgery, what is the next year of my life going to look like? If I choose to do chemo, what are the short-term and long-term side effects of chemo? If I don't choose to do chemo, what is my life going to look like? So if they want to do a procedure, an MRI, if I have the MRI and we find cancer in my 93-year-old demented mother, what are we going to do with the results? Are we going to do surgery or radiation or chemo on my 93-year-old demented mother? Probably not. So maybe we shouldn't do the MRI. And we've gotten so used to just doing everything. I'll just send them for an MRI. Move them out of their bed onto a stretcher in the hall with a mask in an MRI machine that makes a lot of noise. They're confused. People they don't know, back on the stretcher, back in the bed. That's a lot for a demented patient that has problems with confusion to just send them for an MRI, which is going to give us a result that we may or may not do anything with. So it's really understanding the procedures that we do, what's the risk and what's the benefit.
That is interesting. So I don't think that's a question that families are generally equipped to ask because we're so used to following whatever the healthcare provider is suggesting.
Absolutely.
I'm also thinking about COVID, and I hate to bring up COVID, but it is on everyone's mind right now. You did a considerable amount of work around COVID, correct?
Yeah.
Can you talk about?
I was a frontliner.
Please talk to me about that and how that has affected you and how you think it's going to affect our healthcare delivery system.
Well, I'm over 60. If you had said to me in January, what do you think about working 10 hours a day, 7 days a week for the month of April? I would have said, no, thank you. I'm not interested. But I worked 25 days the month of April, 10-hour days, sometimes 7 days a week. I didn't have weekends off, and it was just busy. I remember in the beginning thinking, oh, this is just like AIDS. I started as a nurse in 1980 when the AIDS epidemic started. And I'm like, oh, we've done this before. This is just like AIDS. We can do this. But very quickly we realized it wasn't like AIDS. It was difficult. You just do it. When you've been a nurse for so long, you just do it. You were everything. One day, my funniest story is we used to have these machines in the rooms that had negative airflow to take the air out, and the machine wasn't working. Now, you were doing everything. The dietary would leave the tray outside the room because they wouldn't go in. So when you walked in the room, you'd bring the dietary tray. You'd be at the desk, the phone would be ringing, nobody would be there, you'd answer the phone. You'd be in the room and the aide needed help and you'd help the nurse's aide change the patient. You were the advanced practice nurse, you're writing orders and you're, doing medicine. So this thing breaks in the room. I go in, it's not working. And I call maintenance and I'm like, this thing isn't working. He says, well, just play with the on-off switch. I said, listen, I'm the dietitian. I'm the secretary. I'm the nurse's aide. I'm the nurse. I'm the advanced practice nurse. I am not maintenance. I mean, everybody was doing everything they could. We all had so many hats and so many jobs just to take care of people. And then, it slowed down, it got better, and you thought things are good until I sat down one night to watch Grey's Anatomy, which is a show I've watched forever. And Grey's Anatomy started the show off with a sign that said April 2020. And I already started to feel uncomfortable. And then the rest of the show could have been me on the show. And they were saying, our patients are dying, we don't have families here. And they were saying, we hit 100. And I remember when we hit 100 at our hospital, 100 deaths. And it was horrible. It was just horrible. And I didn't realize until I was watching Grey's Anatomy crying in my living room thinking, I think I'm having PTSD. Like I had never had PTSD in my life. But now I'm reliving the stress and the trauma that we lived through in March and April in Jersey. I mean, it was difficult. But part of that was why I developed these online programs for patients and families, because I realized that, of those thousands and thousands of people that died, many of them had not had conversations with their families. Everybody thinks it's not time. Everybody thinks it's not time. all of those patients that died, most of them, their families said, I don't know what they would have wanted. We never talked about it. So if that is not a call to action to people to talk about what they want, and COVID is still going on. I mean, we're getting vaccinated. I've been vaccinated. Our numbers are going down. This is good. But we still have people dying of COVID in the hospital. And we still need to have conversations about, if this happens to us, what would we want? What is important to us? How do we want to live our life? If we were going to live our life in an institution, is that the way we would want to live? And if the answer is no, then sometimes we need to stop doing all the things that we do. And you had said that before. You had said, how do we make things different? I've heard it described when you come to the hospital, it's like you get on a train and there's no stops. You just keep going and going. Let's do this test. Let's do that test. Let's do this antibiotics. Let's start dialysis. Let's do surgery. Let's do this procedure. And nobody ever says, stop. What are our goals here? What are we getting out of this? Are we getting better, or are we getting worse with all of these things that we're doing? And if we're not getting better, then at some point we need to stop and say, okay, let's regroup. What's our plan? We've done this, and this. We're still not better. We're worse than we were when we came in. This is what the trajectory looks like. What should we do now? And I think that's another good point to mention to families, because families are always afraid. They just listen. They listen and the doctors say, we're going to do this, we're going to do this, we're going to do this. And nobody ever says, stop. Why? Why are we doing this? What are we going to get out of this? How is this going to benefit my mother? How is she going to get better now if we do this? And these are the questions that we have to ask. Get off the train.
At what point, after you're admitted to the hospital, at what point could a family do that? Could they say, okay, let's stop, let's reassess, let's really plan on, is what we're doing in the best interest, and is that going to meet the goals of my loved one?
It can happen anytime, depending on what your situation is coming in. I mean, we have patients coming in from nursing homes that are in their 90s, that have dementia, that aren't talking, that aren't eating, that have lost weight, that have bed sores, that are contracted. So if that's the situation coming in, then that conversation should be held on day one. And very often I'm called in the hospital to have that conversation on day one. Do you want to go to the intensive care unit and give full press and do everything? Or do you just want to try some antibiotics, IV fluids, see how we do, nothing super aggressive, see if we can get them better, and then regroup in another week? If you're young and healthy and you're 50 and you come in with something and you're in the hospital 3 weeks and things aren't going the way they should be, certainly that's the time you stop and say, okay, let's sit down. Let's get all the team together, which is often hard when you're in the hospital and you're seeing an infectious disease doctor, a pulmonary doctor, a cardiac doctor, your generalist doctor. You've got 4 or 5 different people seeing you and you're getting different pieces. I remember when I worked in ICU, I'll never forget the story. And, there was a patient who was in and he really wasn't super, super sick. He was going to get better. And the wife had been talking to all the specialists all day long. And he was old. He was in his 80s, and the wife said to me at the end of the day, have you ever seen anybody this sick? And he really wasn't that sick. But because she had gotten so much information from 5 different doctors all day long and trying to process, the heart doctor says he's doing good. The lung doctor says he's doing bad. The infectious disease doctor says he's holding his own. And then at the end of the day, the family has to figure out, are we in the right direction or the wrong direction? Are we getting better? Are we getting worse? Are we staying the same? Sometimes we just have to stop and ask that question.
How can someone access your online education?
They can go to the website, www.palliativerx. They can contact me via email, franhoh@comcast.net. Those are the 2 ways.
That's my first question. My second question is, if you're not in New Jersey, what do you ask for if you're in the hospital and you're a family and you would like to have a consult the way that you
can ask if they have a palliative care team. I think, I don't know the exact number, but I think it's somewhere around 90% of all hospitals in the country have palliative services. So you can just ask to see the palliative care team at any time, especially if you have COVID, I would ask.
Is there any question that I have not asked you that you thought I was going to ask you today?
You were good, Marley. You asked me all the things I was prepared for.
That's good. That's good.
No, I just, there's no question. I would like to say one thing, though. April 16th is National Healthcare Decisions Day. So if you have not thought about and talked to your family about what you want to do in the event that you got very sick, in the event that anybody could have a catastrophic thing at any time. You could have a major stroke, a major heart attack, a bleed in your brain. You could get hit by a car. Anything could happen that could leave you unable to speak. And if you are unable to speak, your family's going to need to decide. And a lot of patients say to me, oh, my kids will decide. That's a big burden to put on children, to decide whether or not to continue the ventilator or the respirator or life support, whether to start hemodialysis, whether to put a tube in to feed you. This is something that you really need to talk to your kids about. And April 16th is National Healthcare Awareness Day. So you can go online, you can look it up, you can get lots of information. We are doing a charity event. We are creating stress relief kits, and we are going to be distributing them to 300 patients that are undergoing chemotherapy as a community service to patients in our community. Something to get the community together, something to focus on National Healthcare Decisions Day, and just something to give back people that are struggling with serious illness. So if that's something that, anyone would like to participate in, no matter where you are, you can call me and I can, give you information on that. That'll be on the website shortly.
And is that April the 16th every year? Or is that just this year?
Every year, April the 16th.
Well, that I certainly, from having been in geriatrics for 40 years, I know that that's one of the important things that you do need to do for yourself and for your family. So,
right.
Fran, thank you so very much. You've been a wonderful guest today, and a topic that I think we need to continue to educate about. So good luck to you, and I hope that you have lots of successes in your future, and I hope that means some change in the healthcare delivery system.
Thank you so much, Marilee. It was great to be here, and I hope I gave your listeners some tips that they can really, utilize in their family lives that can make their life better.
Thank you. I believe you did. Have a good day and stay safe out there.
Thank you.
Thank you so much for listening today, and a special thanks to our sponsors and partners, National Association for Home Care and Hospice, Access, and Core Cubed. If you've not done so already, please subscribe to our podcast and take the time to leave a review on Apple Podcast. We are now also on Spotify and most other places where you find podcasts. Like and follow us on social media and join us. Want you to spread the word and help choose home when care is needed.